two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare podcast. This is our episode number 108. And today I'm joined by my co-host, Dr. Jose Checo. Welcome, Dr. Checo.
Good evening, Swapnil. How are you?
I'm good, thank you. Today, we are going to discuss another interesting trial in our ICU Journal Club, which is INCEPTION trial. Now, this trial is around evaluating the efficacy of eCPR or extracorporeal CPR in patients who had out-of-hospital cardiac arrest secondary to ventricular arrhythmia. So I guess this is a quite interesting trial and has given some important signals with regards to the efficacy of this intervention. When you look at some of the reason why we do eCPR in patients with cardiac arrest is predominantly because the survival rate in out-of-hospital cardiac arrest secondary to ventricular arrhythmia still remains around 50%. And I guess if we do not achieve return of spontaneous circulation after standard CPR, then I guess we do not have any other modality to institute in terms of achieving more survival. And that's why eCPR has been tried and tested over the last decade or so in various centers with various experience to see whether we can improve the survival rates in patients who develop in-hospital or out-of-hospital cardiac arrest with shockable rhythm. So I guess with regards to evidence that is available so far, it's quite interesting. There are two randomized controlled trials and there are few prospective observational or prospective cohort trials performed to date, which have given various signals. And that's why this trial is quite important. Now, so the first large randomized controlled trial, which was performed on this topic, was ARREST trial, which is Advanced Reperfusion Strategies for Refractory Cardiac Arrest trial. This trial compared the use of highly standardized extracorporeal CPR pathway with the use of conventional CPR. And this trial was actually terminated early owing to difference in survival of 36% point in favor of patients who received extracorporeal CPR. Now, ARREST trial enrolled only very modest sample size. It included only 30 patients, even before they terminated a trial prematurely. And I guess that was a kind of main criticism along with this trial was a single center trial. And potentially this improved mortality could have been due to chance rather than the actual signal. Subsequently, there was another single center randomized trial conducted in Prague called as Prague OHCA trial, which was reported in 2020, involved 264 patients with witnessed out-of-hospital cardiac arrest who did not have a return of spontaneous circulation within 5 minutes of initiation of CPR. And in this trial, patients were transported to the trial cardiac center and randomly assigned to receive either extracorporeal CPR or continue conventional CPR. Now, similar to INCEPTION trial that we're going to discuss today, this trial was conducted in a very well-developed EMS or emergency medical services environment or where there's a more kind of advanced paramedic support is available. Now, Prague OHCA trial, the survival to 180 days with a favorable neurological outcome, again, was not different. And the Prague trial was terminated early for futility after assessment of 256 patients, with the primary outcome having been observed in 32 patients in eCPR group compared to 32% in the conventional group. And this trial also noted that there are more complications associated with eCPR, such as bleeding or infections. So I guess Prague trial showed that eCPR did not improve outcomes as compared to conventional CPR. Now, with regards to our local experience, we do have couple of prospective observational and prospective cohort trial called a CHEER trial and 2-CHEER study. Now, the 2-CHEER study is the latest of two, which was published in 2020 in Critical Care Resuscitation Journal, was conducted in Sydney, New South Wales. And this was a prospective cohort study of patients with refractory cardiac arrest conducted between two hospitals, St. Vincent and RPA. And this trial has actually demonstrated that there is a benefit in terms of overall outcomes and neurological survival with eCPR compared to conventional CPR. And I guess that's why the conclusion was the survival rates were encouraging. However, the large multicenter trial is needed to confirm these results. And even in this tier 2 study between two ECMO centers, only 25 eligible patients were enrolled over the period of 2.5 years. And that itself suggests the complexity of this problem, where recruitment can be quite slower if we have a very stringent inclusion and exclusion criteria. So today we are going to discuss a major landmark trial called the INCEPTION trial, which evaluated the efficacy of extracorporeal CPR as compared to conventional CPR with regard to survival with a favorable neurological outcome in patients with refractory out-of-hospital cardiac arrest secondary to initial ventricular arrhythmia. So, Dr. Chaco, can you please walk us through the methodology and the results of this trial, please?
Yes, Swapnil. The INCEPTION trial was a randomized controlled trial conducted between May of 2017 and February 2021. It included 10 cardiosurgical centers served by 12 EMS services in the Netherlands. Adult patients between 80 to 70 years old were eligible if they had sustained a witnessed refractory out-of-hospital cardiac arrest with ventricular fibrillation, ventricular tachycardia, or any other shockable initial rhythm. Refractory cardiac arrest was defined as failure to attain ROS within 15 minutes of arrest. Patients were randomized in a 1-to-1 ratio to eCPR or conventional CPR. They excluded patients who attained ROS within 15 minutes, those with terminal heart failure, severe COPD, disseminated malignancy, pregnancy, patients who had bilateral femoral bypass surgery, obviously in whom cannulation may not be possible, other known contraindications for CPR, or an expected duration of more than 60 minutes from the time of arrest to cannulation. So if they felt that it would take more than an hour between the cardiac arrest and cannulation, they were not included in this study. Patients with a poor neurological state at baseline were also excluded. In fact, the inclusion criteria were reviewed once the patient was brought to hospital. Patients who were randomized to eCPR but took more than 60 minutes for cannulation were included in the end. eCPR was not performed if ROS was achieved before initiation, but were analyzed based on intention to treat. Post-resuscitation care, including targeted temperature management and conduct of extracorporeal circulation, was based on local practices and current guidelines. So what did they do in the eCPR group? Percutaneous surgical cannulation of the femoral vein and the femoral artery was carried out. The eCPR circuit was chosen based on local availability. A distal cannula for lower limb perfusion was encouraged but was not mandatory. Chest compressions were carried out throughout this period with minimal interruption. The post-resuscitation care included targeted temperature management to 33 to 36 degrees centigrade for 24 hours in both groups. Normothermia was attempted for 72 hours. Mechanical ventilation was carried out as usual to maintain normal PCO2 and PO2 levels. A target mean arterial pressure was set at 65 to 70 millimeters of mercury. And of course, they would do coronary angiography and revascularization procedures as appropriate among their patients. How did they calculate the sample size? The authors hypothesized an improvement in 30 days survival with a favorable neurological outcome. So that was the primary endpoint. They expected an improvement from 8% in the control group to 30% in the eCPR group. And thus, they calculated a sample size of 49 patients in each group. However, as several patients who were assigned to eCPR achieved ROS before cannulation, these numbers were actually revised to 134 with 67 patients in each group. The results of the study: a total of 160 patients underwent randomization. 26 were excluded. The reasons for exclusion were unwitnessed arrest, older than 70 years of age, unshockable initial rhythm, and attainment of ROS within 15 minutes. In the primary analysis, 70 patients belonged to the eCPR group and 63 to the conventional group. The mean age of these patients was 54 versus 57 years in the eCPR versus control groups. Nearly 90% of subjects in both groups were male. Both groups were otherwise well matched at baseline. Witnessed arrest occurred in roughly 98% of patients of the whole cohort. CPR was begun within 5 minutes in 99% of patients in the eCPR group and 95% of patients in the conventional group. The cardiac arrest to ambulance time was 8 plus minus 4 minutes in both groups. Arrest to ER arrival was 36 minutes versus 38 minutes. The number of defibrillation attempts were also similar, 8 versus 9. In the eCPR group, 18 of the 70 patients did not receive the intervention as planned. Among these 18 patients, a stable ROS was achieved without eCPR in 13. Logistic failure meant that they couldn't have eCPR in 3 patients, while discontinuation of treatment was carried out in another 3 patients. So there were 62 patients remaining, and among them, cannulation and extracorporeal circulation was successfully carried out in 46 patients. 3 patients crossed over from the conventional to the eCPR group, which was allowed by the protocol. A stable ROS was achieved in 26% of the patients in the eCPR group and 31% in the conventional CPR group. So let us look at the important clinical outcomes. As I mentioned, the primary clinical outcome was a 30-day survival with a cerebral performance category score of 1 or 2 at 30 days. So CPC 1 or 2 means independent activities of daily living. So 30-day survival with CPC 1 or 2 with independent activities of daily living occurred in 14 of 70 patients in the eCPR group. This is 10 of 63 in the conventional group. So that was 20% in the eCPR group and 16% in the conventional group who had a good neurological outcome at 30 days. Survival with good neurological outcome at 30 days. But this difference, 20 versus 16, although numerically higher with eCPR, was not statistically significant, the odds ratio being 1.4 with a confidence interval of 0.5 to 3.5, which meant it was not statistically significant. The 6-month survival with CPC of 1 or 2, which was one of the secondary outcomes, was exactly the same, 20% versus 16%, again, not statistically significant. They also looked at 3-month survival with CPC of 1 to 2, which again was almost similar, fell short of statistical significance. eCPR was associated with a higher survival to ICU admission. Of course, this doesn't mean very much in the whole picture. Survival to ICU and hospital discharge were similar between the 2 groups. Adverse events per patient was roughly 1 and similar in both groups. Discontinuation of treatment based on clinician judgment was carried out in 80% of patients in both groups. The reason for discontinuation were unfavorable neurological state, multi-organ failure, cannulation failure, non-availability of further treatment options. These were the reasons for discontinuation of treatment. So this study essentially showed that eCPR compared to conventional CPR among patients who experienced out-of-hospital cardiac arrest with a shockable initial rhythm and a refractory cardiac arrest of more than 15 minutes to achieve ROS did not result in any improvement in the 30-day survival with a good neurological outcome in the eCPR group compared to the conventional group.
Thanks, Dr. Chakos. This trial, as I mentioned before, it's quite a landmark trial on this topic because this is another large randomized controlled trial on this topic. It has given a signal that eCPR is not as effective as standard CPR. Now, before we kind of jump into the conclusion, it's very important to tease out some of the key aspects of this trial. This trial was conducted in Netherlands, where the EMS or the paramedic system is quite well developed. And that's quite evident even when you look at some of the baseline characteristics, where the arrest occurred at home was roughly around 44%, and a number of arrests witnessed were 97 and 98% in each group. And in both groups, actually, the CPR was started in less than 5 minutes after the arrest in 99% in eCPR group versus 95% in conventional CPR group. So that's the kind of reflection of how well the basic life support is in this country to start with. Also, the transport distance for patients in both groups to the centers where they can have eCPR instituted was only around 17 or 16 kilometers in both groups, which again highlights that the importance of time when we talk about these kind of interventions. Because realistically, getting the patient in hospital and on ECMO within first hour is the key thing for overall outcomes. And achieving those outcomes in subcontinent or third world countries is going to be very challenging. So the overall generalizability of this trial can be quite questionable. And I guess this intervention has got very specific place in specific settings where these timings can be achieved. And that's why even places like Sydney or New South Wales, where we do have advanced intensive care settings available, not every single ICU is capable of performing this intervention. And I think that's the first caveat before we interpret the results of this trial. Now, when you look at the overall time crunch that you need to understand, is start of the arrest to arrival to the emergency less than 30 minutes. So patient has to come to emergency department within 30 minutes. Start of the cannulation need to happen within first 60 minutes of the cardiac arrest. And the cannulation process in this trial took only around roughly 20 minutes. So that means the whole system need to be set up even within the hospital in such a way that your team is ready to kind of perform this cannulation, and the cannulation can be performed within a very short period of time. So time is the key determining factor when we assess these interventions. And that timing is very difficult to achieve because this trial did not have a standardized protocol for all centers. So every center kind of did their own thing with regards to performing the VA cannulation and putting the patient on ECMO. While if you look at the previous trials, or especially the single center trials, they had a very set protocol and only one protocol was followed. While in this trial, clearly because of the limitation with the multi-center nature of the trial, the different protocols were followed with regards to commencing eCPR. So I think that's the difference between the previous trial and this trial. Now, 32% of the patients in the intervention group in the arrest trial survived with a favorable neurological outcome at 6 months compared to 22 in patients with control group. However, 27% of the patients in the intervention group and 44% in the patients in the control group had sustained ROSC at the admission itself. And similarly, in INCEPTION trial, 26% of the patients in intervention group and 31% patients in control group regains ROSC without eCPR. And I think that again highlights that if you perform a very good quality standard CPR, you are likely to get good outcomes and you might avoid this very invasive, resource-intensive intervention in almost 30% of the patients. So sometimes decision-making can be challenging. And then I guess if you stick to the standard CPR algorithm, I think you might be able to get away without doing the eCPR in 30% of the patients. So I guess the generalizability or external validity of this trial itself is quite questionable. Now, when you look at some of the data from the other trial, like CHEER trial or CHEER study from Australia, which are prospective cohort studies performed in the specific centers, they had almost 50 to 57% survival rate in patients who underwent eCPR. While in this trial, the 30-day survival was only 20% in eCPR group. So consistently, multi-center trial on this topic has failed to replicate the results from single-center prospective observational studies. And that's, again, mainly because of each center has to achieve a certain level of experience and expertise in performing this very complex intervention in order to achieve those higher survival rates. if we perform this intervention in every single ICU or every single center with a limited experience or limited resources, the overall survival rate is not going to be that great. In fact, it takes around a decade or so of learning curve for any center to become expertise in this area. So I guess that's the main problem with this study. And I guess multi-center nature is always good because this adds more generalizability or more pragmatism to the study. Having said that, this topic is quite complex, where a multi-center randomization might not work as good as a single-center randomization. However, the trial is well conducted. It's a pragmatic design. So that's all strengths of the study. Now, there are limitations of this trial. This is obviously unblinded trial. The paramedic personnel knew about this trial. So whether there was a bit of bias in terms of transporting these patients quicker to the centers who can perform eCPR is hard to exclude. And obviously the masking or treatment was impossible. So that led to a crossover of 3 patients, all of whom died despite receiving eCPR. So these are the kind of major limitations. However, this trial does provide quite significant valuable data on this topic and just reminds us that when we perform these interventions, we need to choose our patients really carefully and really need to have a robust setup ready to go if we are going to undertake this kind of intervention in our hospitals. So these are kind of my initial thoughts. What's your thoughts, Dr. Checker?
Well, conceptually, the concept of eCPR seems physiologically plausible and a very attractive possibility as well, because it allows you time to maintain organ perfusion and to alleviate neurological damage in cardiac arrest when you're not able to attain ROS with conventional measures. And it also offers a window of opportunity to you to identify the underlying cause of the arrest, which in most cases is likely from acute coronary syndrome. So it gives you the time to stabilize things and intervene, including coronary revascularization. So conceptually, it seems very attractive. But then when it comes to ground level, of course, there are several bottlenecks to success. And that's what we see as well in these trials. Although these were centers that were very much adept at doing eCPR in fairly quick time, it didn't really reflect in terms of the important clinical outcome, which is neurological function at 30 days in this INCEPTION trial. So overall, I suppose, as a rule, you wouldn't recommend the use of eCPR based on the available evidence from these 3 randomized controlled trials, the ARREST trial, the Prague trial, and the current INCEPTION trial that we discussed. But of course, it depends on the situation. The other day, we had a very young patient who presented with out-of-hospital cardiac arrest. And even after some 20-25 minutes of CPR, there was no sign of ROS. So we were seriously considering doing eCPR at that point of time. So there may be the occasional case in which you might still consider, even though the generalizability of these results cannot really be taken for granted. So overall, the study is, of course, an eye-opener, and I'm sure there will be many more studies evaluating the same question in the future. And hopefully, we will have more answers as we go. But I suppose the most important problem, as you rightly suggested, is to have things organized such that time, being the key, allows you to carry out these procedures rapidly, like insertion of cannulae and getting the eCPR going, should be done as quickly as possible. So therein may lie the possibility of success.
Yeah, that's right. And also, if you look at this trial only evaluated the outcomes in patients who had witnessed cardiac arrest with primary shockable rhythm, which is predominantly ventricular tachycardia or ventricular fibrillation. This trial did not give any answers regarding in-hospital cardiac arrest with any other rhythms. Obviously, the reason being VF or VT cardiac arrest considered to be more prognostically favorable, and VA ECMO success rate is going to be always higher in those patients compared to non-shockable rhythms. And I guess we still don't know what will be the utility of this intervention in those specific subset of patients and whether they will benefit from eCPR or not. But at the moment, it seems like the use of this intervention is quite niche and need to be very specifically considered in a select subgroup of patients in consultation with the centers who has much more experience in performing these interventions. And sometimes transporting these patients to those centers in timely manner is probably the better solution rather than every center starts doing eCPR on their own. Just based on this trial, I guess it's very hard to say that do not do eCPR at all in any center or in any patient. I think that's clearly not the message from this trial. I guess the key for success of this intervention is going to be a case-by-case basis selection of the patients or personalized medicine approach, whether that particular patient will benefit from this intervention based on the time and the location and the initial presentation. So that's the end of our today's podcast. We'll be back with another episode in fortnight's time. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening in. Till we meet next time. Goodbye.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.